Welcome to Sense and Sustainability, an organization dedicated to providing rigorous but applied perspectives on sustainable development. You're listening to the SNS podcast. You can visit our website at senseandsustainability.net, where you will find an archive of all previous podcast episodes in addition to our latest publications. Thanks for tuning in.
Welcome to SNS, everyone. I'm your host, Ji-Sung Park, and our guest today is a very good friend of mine and a frequent contributor to Sense and Sustainability, Dr. Abdul Sayed. Abdul, thanks for being with us.
Thanks for having me, G.
So, I should mention, not only is Abdul a frequent contributor to SNS, he was the first podcast guest way back when. Do you remember that?
I do. It was good times.
Yeah, man. So yeah, thanks for being back on the program. We're going to try something new today and split the podcast into two shorter segments. In the first half, both of which will be situated around the general idea or the general issue of public health and healthcare systems, particularly in the U.S. So in the first half, let's talk big picture ideas. What's the current state of the U.S. healthcare system? What are some of the ways in which we can try to fix it? Big picture policy-oriented ideas. And then the second half, we'll talk more about process, dipping into some of your experiences as both a medical student and a PhD student/researcher, what it's like to be in a hospital, some of your observations, particularly geared toward, undergraduates, pre-med students, folks who are interested in the healthcare field, but who haven't quite had as much exposure as you have. Sound good?
That sounds great. Thanks for having me back. I mean, you guys have come a long way. I've been an avid follower, and I'm excited to be back, and especially to be talking with you. So let's do it.
So let's start with 30,000 foot view. U.S. healthcare system. We recently passed the Affordable Care Act, also known as Obamacare. Before we get into the specifics of Obamacare, Abdul, what in your mind is the state of the U.S. healthcare system as a whole? And if you had to give it a grade, right, putting on your sort of teaching research hat for a second, well, what grade would you give it, A through F?
So, unfortunately, I'd have to give us a C. When we talk the U.S. healthcare system, three big ideas come to mind, right? There are three big quandaries, really. The first is what people in public health like to call the healthcare gap. And that's the idea that we spend considerably more than any other OECD country on healthcare. Mm-hmm. And despite that, our healthcare metrics are middle of the pack to below average. So when you're looking at big picture metrics that public health folks like to look at are things like life expectancy, all-cause mortality, infant mortality. And when it comes to all of those metrics, we're punching substantially lower than one would expect given our expenditures. So that's the first issue. The second issue is the fact that our healthcare costs aren't just increasing linearly, they're actually accelerating. And that's already in the context of recognizing that we spend more than any other country already. Near accelerating cost in the setting of already spending way too much, that's a big problem. And then really the third issue, and one that doesn't get talked as much about in the lay conversation about public health, are increasing disparities in public health. So when you look at differences in infant mortality or all-cause mortality among blacks relative to whites or among poor folks relative to richer folks, you see that the differences are growing, and that's a big problem. So whether it be relative to other countries or relative to how much we spend or relative to one another, we don't produce the kinds of health outcomes that we would like. And so for that reason, I have to say a C. Now, why a C and not an F?
Because you're a generous grader, obviously.
Of course I'm a generous grader. I want to see us pass. But really, I'd say not an F because of institutions like the NIH.
Okay.
And, I have to say the quality of our health research in general. In a lot of ways, the American consumer subsidizes most of the healthcare research that happens in the world. And so many of the advancements that we're seeing, both in terms of care for acute issues and chronic issues, and also infectious diseases, which sort of get more ignored than they ought to be, a lot of that is because of our healthcare system. Now, that has some negative consequences, but for the most part, that's certainly a big plus. And if you have the money in the United States for an individual can get excellent care, probably better than anywhere else in the world. And so for that reason, I'd say C rather than F.
So a lot of things I want to try to unpackage in what you just said there, Abdul. Just to reiterate, you said 3 issues: healthcare gap, costs are accelerating, and the disparities are already large and widening. As you say that, I can't help but think that those problems are also very much epitomize the issues associated with the U.S. education system as well. And I wonder to what extent, and this can be somewhat armchair economic or sociological, the disparities part in particular stem from common causes, or to what extent they're endogenous. So because you have poor health, you're poorer income-wise, and that kind of leads to a cycle. I'm sure the jury is still out on that in terms of robust empirical evidence, but I'd like to get into some of your ideas there too. Let's talk about the healthcare gap first, though. So, like you said, in terms of outcome metrics, we're lagging behind most other OECD countries. Is this mostly because of the lower tail? Because in education, that seems to certainly be the case, right? The sort of really, really underperforming 10% of the distribution pulls down the mean score. So the U.S. looks really bad on international test scores, but if you take out the lower, like the really bad 10%, it's actually not so bad. Is that true in healthcare as well, or is that only education?
That's partly true. No, so interestingly enough, those 3 problems are really just different sides of the same triangle, we'll say. Because if you think about it, the fact that we have accelerating disparities tells us that we're having a lower tail that's doing substantially worse relative to everybody else. And that costs a lot of money. But then what's worse is that we sort of build institutional fixes that we have are imperfect and sort of accelerate both problems. So just an anecdote. You think about if you're poor and uninsured in the United States and you're a diabetic, your access to basic medications, your basic metformin, or if you're on insulin, your basic insulin, is pretty low. And you don't really know where your next dose is coming from. So what happens is it's so hard to get, and on top of that, the reason that you're uninsured is probably because you're poor, right? That your resources are being competed for with respect to other things that you need to do with your life besides take care of your diabetes. And so the diabetes gets worse, and what happens is you come into the emergency department with an acute exacerbation of the diabetes. And at this point now, the emergency department can't just treat your diabetes. They need to make sure that they're covering the rear end for everything else. So the costs, paradoxically, are actually higher to care for you because you're uninsured than they would be if you had insurance and could have just accessed the medications without going in to ketoacidosis or whatever complication. And so, you think about that, that's going to accelerate the costs substantially. And what's worse is that, we're going to talk about Obamacare, I'm sure, a little bit later, but it's really hard to undo a lot of these quick institutional fixes that really, in the long run, complicate things. And so that's just one anecdote. The other side of it is also that if you are uninsured, for the most part, your access to care is spotty. And you think about who is uninsured in the United States, disproportionately black, disproportionately poor. And what's worse than not having access to care is that highly, and this is, again, something that we don't focus enough attention on in the policy conversation, is that the places that you live in and the lack of opportunities that you have are really things that are making you sick to begin with. So not only do you not have care, but you're more likely to get sick to begin with. And that sort of explains that accelerating disparity that we're witnessing, but then also sort of clues us into why our healthcare is getting more expensive. Another comment on that also, though, is that when you think about something like healthcare, our society, and you and I have talked about this quite a bit, our society hasn't necessarily come to terms with the fact that everybody dies. The problem, though, is that we built a system entirely founded upon curing people. And I know we'll touch on this a little bit later, but what happens when you have a system that's founded upon curing and the inevitable reality of death? What do you do when those two things go head to head, right?
And if the cures that are administered later and later in the process of illness or in life generally are more expensive systematically, then you've got you're setting yourself up for failure almost.
Exactly.
In that sense. Yeah.
You spend a disproportionate amount of Medicare dollars on the last month of life.
Do you know what the numbers there are like?
I can pull those up for you.
We can put them on the site, later. But I just remember you telling me that they are absurd.
It's astronomical. But all of that is to say that part of the problem is cultural, is that we haven't necessarily come to terms with the fact that our health care and our health care resources are limited. And perhaps it's not the best idea to be spending a tremendous amount when death is the inevitable outcome that we all know is going to happen. So Medicare spent $50 billion on the last 2 months of life in 2009. That's 25% of Medicare costs in the last year of life. And 40% of that 25% is spent in the last month.
So this is obviously things like ICU treatment or just all of the last gasp efforts to keep someone who's dying of cancer alive.
Exactly. Intubation, ventilation, keeping people on complete life support. These things cost a lot of money.
Let's not poo-poo the complex emotional side of that treatment coin, but I think you're right to say that at a systemic level, Abdul, I mean, our society, I would maybe go so far as to say Western civilization in general is sort of, we kind of haven't figured out what to do with this whole death thing. As Carl Jung put it, I think, death is sort of like the sun. We can't stare at it for more than a second without looking away. It seems like in the U.S., our healthcare system is just in denial of the fact that we're all going to die. Yeah, and it seems to show up in these metrics, like you say.
Absolutely. And that's not to be insensitive, like you said, to the realities of losing loved ones and having to face a very difficult loss. That is to say that culturally, there's a role for talking about death in a way that sort of demystifies it and allows us to come to terms with its reality. And then when it hits, maybe we're a little bit more receptive to the recognition that this person is going to die, and despite my best efforts at keeping him or her alive. So it's a very painful situation to watch, but it's even worse sometimes, having been in the clinic, watching family members who maybe estranged fight over what to do with the patient who's been on ventilation for the last several days, and we're just really dragging their body through the mud, and it's painful, right? They're going through real pain, and you wonder how much money is being spent to put this person through agony in the last several weeks of their life, and that's a question. If people could understand it that way, I think it'd be a lot easier entree to the type of conversation that we need to have.
And not to belabor this point too much, nor to appear or sound insensitive to the real depth of suffering at hand there, but I imagine that in many of those cases, there's a lot of avoidance of necessary psychological pain going on when you insist on dragging your grandma through a battery of surgeries and tests upon surgery upon test. Just maybe, and again, I don't want to judge, but maybe to avoid accepting the inevitable in some cases. But you can speak to that better than I can because you've actually been in those situations way more frequently as a medicine resident, which we'll get to in the second half of today's podcast. I'd like to sort of get us out of the muck of end-of-life care for a minute and back to higher elevation, let's talk about the cost side of things for a second, if you will, Abdul. When Obamacare was being debated and after it's been signed into law, ostensibly one of the main reasons behind pushing it forward from the president's perspective was to try to manage costs, right? I know that's not the only part of it, but tell us a little bit about what Obamacare does actually, because I think there's a lot of confusion about that, and to what extent it actually, the way it's designed, to what extent it can actually address some of the cost acceleration issues, and maybe to what extent it is designed to fall short.
Right. So our healthcare market is an insurance-based market. Insurance has this awkward problem wherein the people who need insurance most are the people who are most costly to the insurance system. And so what happens is when people don't need insurance, sometimes they get out of the insurance system, which then leaves, if you think about insurance as pooling risk, it leaves the riskiest folks in the insurance market who are also the most costly, which
exactly
the cost of that insurance. And
yep.
Your folks call that adverse selection. And so our healthcare market, one of the big problems is that young, 20-somethings like you and I, when we're making a decision about whether or not we want some extra money for the weekend versus wanting to pay insurance costs, unfortunately, too often we make the former decision. And so that leaves a market of higher risk older folks, making that market substantially more expensive and increasing the cost of healthcare overall. And so what the goal of Obamacare from a 30,000-foot view is to sort of force us all back into the market. Now, that's the question of forcing somebody into a market. That was a question that was debated by the Supreme Court. I don't think neither you or I are in the best position to talk about that, but that's the idea. And then what that does is says, well, we know that we're going to force you into the market, so we're going to make that market a little bit more acceptable by subsidizing your particular insurance. And then it also forces, in the same goal of keeping healthy people in the market, it forces employers to purchase insurance on behalf of their workers or to subsidize their insurance costs if it doesn't provide them. So that's the basic idea. And then beyond that, it also restructures some of the incentive issues around fee-for-service healthcare. So in the United States, when you go to a doctor, you pay that doctor for the services that they perform for you. But you could see why that would be a problem if you use the analogy of a mechanic, right? You go to the mechanic, you know something's wrong, but you don't know exactly what's wrong or how much it's going to cost. Now, the mechanic whose responsibility it is to fix the car also tells you what's wrong with it, and you can see where there's a conflict of interest there. In that sense, the doctor's incentive is actually to upsell you, right? Is to increase the cost of healthcare overall, or aligns with increasing the cost of healthcare overall. And so one of the goals has been to restructure the way that we interact with our doctors around, rather than a fee-for-service system, a fee-for-outcomes system, right? So in that setting, things like accountable care organizations that group individuals together and assign them to doctors, and then what happens is those doctors are paid bonuses based on how well the people in their catchment do. And so those accountable care organizations can be really useful tools for minimizing healthcare costs overall, because doctors now have the incentive to improve outcomes.
So just so we're clear here for the listeners, the fee-for-service model is exactly what it sounds, right? You pay, the doctor gets paid either by the patient or through some intermediary, usually the insurance company, per service rendered, so x-ray, consultations, surgery, whatever, whereas the pay for performance, is that what you call it, or the outcome-based?
Yeah, pay for performance, exactly.
I mean, how do you measure performance, actually, in these?
Looking at outcomes that we think matter, right? Preventive outcomes like how many people have met their colonoscopy requirements, how many women have met their mammogram requirements and pap smear requirements, how many people got their flu shot, right? And based on those types of metrics, the doctors in the ACO or accountable care organization are given a bonus. And so those are outcomes that we want to meet, that we know will save money in the long term, that we then reward, give back some of that money to the doctors themselves for doing a good job.
And that gets to the point about prevention versus cure again that I really do want to talk to you about, although we are running out of time, unfortunately. But I think you were in the process of trying to give us a 30,000-foot view of how Obamacare addresses the issues. Does that sort of sum it up?
Yeah, the idea basically around the cost is to address the adverse selection issue in the insurance market, and also to address the deep misalignment of incentives in the way that service is provided by creating things like ACOs, particularly with respect to patients in Medicaid or Medicare, wherein we save money overall because doctors no longer have the incentive of upselling.
And for what it's worth, I'm obviously no expert on the health side of things, but I can say that in the economics literature, the notion of adverse selection leading to grossly inefficiently high premiums for basically everyone in the population is very, very well established. I mean, people have won Nobel Prizes for theoretical work on that, Joe Stiglitz being one person. And so our sort of political libertarian qualms about, quote-unquote, being forced to do anything by the federal government aside, I think it's safe to say that, in principle, that the idea of everyone sort of bringing down everyone else's insurance premiums by basically solving what is a collective action problem through a mandated insurance system is a sound idea. I don't think it's a controversial one, at least within academia. If you watch Fox News or CNN, it would make it seem much more controversial, but we won't go there. Let's touch briefly on prevention versus cure, and then leave a little bit of time to talk about disparities. So Abdul, we've talked about this many times, and especially over the last year or two, as you've spent a lot of time in the hospital as the MD part of your MD PhD kicks into full gear. You told me many times that there seems to be this deep, almost paradigmatic problem in the way Western medicine is structured around cure, like you said, right? When really it should be about prevention, if anything, or holistic health. So tell us a little bit more about what you mean here and why you think it's the case.
Absolutely. So what I mean here is that the hospital, right, the clinic, if you think about it as an institution, it's a bit of an anachronism. It harkens back to a historical time when most of what people suffered from and died from were infectious diseases. And infectious diseases are imminently curable if you have antibiotics or, particularly with most viruses, all it takes is to make sure somebody stays hydrated and well cared for while their body fights the virus itself. And so we had these institutions, clinics, hospitals, that align very well with this concept of cure because, well, in fact, you could cure infectious diseases. Now, we think about what people suffer from today. The average person in the United States is more likely than not to die of a heart attack or a stroke or cancer than an infectious disease. I mean, in the United States, the likelihood of dying from something like TB or cholera, which mass killers back in the day, absolutely minuscule. The problem, though, is that we built so much onto these institutions. There's a bit of a scaffolding organizational effect. When you see something that works, you start building onto it. And over time, the types of diseases, because we've been successful in fighting infectious diseases, which also our biggest successes were preventive, things like clean water, sewage systems that worked, right? All of these things were preventive against infectious diseases. And because these things, along with vaccinations, along with good acute care for people who are fighting infectious diseases in the moment, we've addressed that problem in most high-income societies. The problem, though, is that we're stuck with this hospital, and we're stuck with a number of industries that make a lot of money off of it. And so there's really not a focus on prevention. I mean, a lot of people pay lip service to it. But let's just consider the incentives for a second of, let's say the average cardiovascular surgeon, okay? Means, well, doctor makes his or her money operating on people after they're found to have cardiovascular disease. Now, if you make your money because people have cardiovascular disease, you'd be an idiot to try and prevent cardiovascular disease, right? And it's just absolutely following your incentives, right? And our entire health system is founded upon curing people after they're sick. That's what you bill for when you're a doctor. Yeah. You don't bill for sitting down and talking to somebody about their obesity or telling them to stop smoking or maybe that they're drinking too much. You bill when you take blood, you give medications, you operate, and that's what makes money. So if that's what makes money, well, why would you stop doing it? And more importantly, why would you stop people from having the very indications for the thing that makes you money? And when you aggregate that up, you realize that our institutions are just not built around preventing disease. That's not what the incentives are. And the problem is that chronic diseases that we suffer today are imminently preventable, but certainly not very curable. People talk about a cure for cancer, for example, and that is, it's an ideal, but it's not going to be achievable anytime soon, particularly not cardiovascular disease or strokes. These are things that we prevent, right? You want to cure a cardiovascular disease, start running now. Eat right now. Don't become obese. Don't become diabetic. That's prevention. Unfortunately, it's too late when it already happens.
right? And just to add on to that, there's a weird sort of ironic circularity and endogeneity in society's attitudes toward health, given that this is the way the institution is structured. Because now, so many people expect when they walk into the hospital after having never worked out or, eaten garbage over 30 years to be like, hey, doc, fix me. Mm-hmm. And the extent to which when you're talking about prevention, we're talking about behavior modification and often very holistic changes in lifestyle. Let's be real. That does not happen unless the patient is on board psychologically as well. But insofar as we've built up an institutional apparatus that encourages people to think in the quick fix kind of way, it only seems to make it worse. And,
the point also from a policy perspective is not necessarily to try and coax people into making good decisions, but it's to try and make those decisions easier to make.
Exactly, right. And to change the incentives, as you were saying earlier.
Exactly.
Systemically, yeah.
Exactly. And that's where we're falling short. And, unfortunately, too many industries, including the health industry, makes too much money off of products that make people sick or treat them after they become sick. And so sickness is that central sort of position. And unfortunately, that means that it's going to become instantiated in our health system, and that's what we have.
Well, on that optimistic note, why don't we close our discussion about sort of big picture healthcare ideas and issues for now. We'll take a quick break and come back to talk about some of the process side of things, especially maybe some of the cultural things that happen within the hospital that may reflect some of these institutional problems.
Have some thoughts you'd like to share about today's podcast? Please let us know by posting them online at senseandsustainability.net or emailing us at senseandsustainability@gmail.com. We'd love to hear from you.